I promised you this would be a little more casual today, and I think it will. We have 4 people with us who someday I'm actually going to bring a crystal ball for this panel. But what I've asked them to do is I've told them that we've spent a day and a half soaking you in lots of Medicaid information, bringing in people from various sort of Venn diagram places. If Medicaid is the middle, then there's corrections and how it intersects, and behavioral health, and what else did we talk about? Patient-centered homes, dual eligibles. So we've done all of that. These folks are going to step back a little, talk about trends, both within Medicaid and larger within health, talk about promising practices in the states, likely developments, particularly that's the crystal ball piece of it. And a couple of them have a few slides to go over. I've told each of the speakers that over the 2 days we've asked you all about burning questions, what's going on in your states, and my kind of boil down of that is that people are interested in how to more efficiently run their programs in their states, what's promising that another state is doing that their state can copy, whether expanding or not. Kind of what are the promising pieces. Everybody was real interested in that exception for corrections that you can in fact pay for hospitalization of prisoners if they're out of the prison for 24 hours in a community hospital and somehow you managed to keep them on Medicaid. So people are seeing that as, ooh, that might be a little savings in my state budget overall. It's fraught with your Medicaid director and your corrections director maybe having some tight conversations somewhere in a budget room. So they're well aware that those are the kinds of things you're looking for. I've also let them know who's in the room in terms of states. You all are really pretty well divided between expansion states and non-expansion states, pretty well regionally divided. So it's a kind of a nice audience. So today, and of course you have more detail in your speaker pieces, we have Kavita Chowdhury, who's from the Pew Charitable Trust. And Kavita, if not yet, soon will know all there is to know about Medicaid and other health spending in states, because that's the project she's in charge of. And she's going to share a little about what's going on in her project. And she's a great resource to have. And I think, yes, we've given you her email address. So you ever have a question, she's your woman in D.C. Leighton Koo is a professor and director of the Center for Health Policy Research at George Washington University. He spent about, 20, 30 years doing health policy advocacy work and development, and is now over on the academic side. And I've specifically asked him, besides his prognostication and crystal ball gazing, to tell us a little about a study he was involved in on the tobacco cessation program in Massachusetts as a possible way to save money in your state. Shelley Gonzalez is with the Center on Budget and Policy Priorities, also based here in Washington, D.C. And Shelley specializes in effective outreach and program simplification strategies to enroll people in Medicaid. And we'll talk some about the programs they're working on and what she sees going on in the states. And then last, we have Matt Hoffman, who is a senior budget analyst for Representative Paul Ryan, who, as you know, is chair of the House Budget Committee and sits on the Ways and Means Committee. And if anybody has at least a view of the crystal ball, I'm not sure whether foggy or clear, it might be Matt. So we've also asked him to do the same kind of presentation. I've asked them each to speak for about 10 minutes, give us some idea of their impressions, and then really we're going to open it to discussion among them and between you and them. Hopefully I won't have to say a word, but if I got to prime the pump or put the microphone in front of your face, you know me well enough at this point to know I won't hesitate. So we're just going to get started and see if we can have a lively discussion.
So it sounds like you've had a pretty action-packed couple of days, so we're going to try to keep the momentum moving here. And thank you for the opportunity to share some of my research. I'm Kavita Chowdhury, and I'm the manager for the State Healthcare Spending Project at the Pew Charitable Trusts. We're a jointly funded project between Pew and the MacArthur Foundation. And some of our goals that we have for our project is to really provide a cohesive picture of what states spend out of their own budgets on everything healthcare related. So we're really trying to help policymakers gain a better understanding of what is driving costs and create a baseline of state level data, which I think is particularly important now as we're implementing the Affordable Care Act and there's so many changes coming down the line. And I'm sure, as you've heard over the last couple of days, Medicaid is the country's largest health insurance program. 72 million people, or for 2013, I think were the most recent estimates. And to give you context for that, that's almost a quarter of the U.S. population. Medicare, in comparison, covers about 16% of the population. In 2012, we spent $429 billion on this program with state and federal funds combined. And what our project is trying to do with this, our latest report, which hopefully is coming out next week, is that we're breaking down this $429 billion to the state level, and we're examining variation between states and trying to identify key cost drivers. So as I mentioned, the data that I'll be presenting will be released hopefully next week, and it's the first in a series of 7 spending reports, starting with Medicaid, moving on to things like CHIP, mental health, prison health care, prisons, I just said that, state government employee benefits, retiree benefits. I mean, it's a long list. So with that, so between 2000 and 2012, Medicaid spending increased by 63%, from $263 billion to $429 billion. Now, while this 63% growth may seem high, this growth is actually on par with overall healthcare spending in the country, which grew by 58% over the same time period. Another way to think about this growth is on an annualized basis. And it comes out to, for Medicaid, growth comes out to about 4% per year after adjusting for inflation. And at the state level, this ranged from less than 2% in about 10 of the states to over 6% in 8 of the states. Now, there's many factors that drive this growth, and each state is very different. So just as an example, Arizona experienced the highest growth, 8.6% growth in Medicaid spending over this time period. And one of the factors that drove the growth in Arizona was that in 2001, they began covering full Medicaid benefits for for childless adults under the poverty level. So in the immediate years following this policy change, of course, there was really large enrollment growth, 20 to 30% per year in the first couple of years after this change. And so that kind of helps tell the story of why Arizona's spending growth was so high for this period. So one of the key drivers of Medicaid spending is the number of people covered by the program. And when we look at health insurance coverage over the last dozen years, we see that as the proportion of Americans covered by employer-sponsored health insurance decreased, especially given, we had 2 recessions in this period, Medicaid enrollment rose by 50%, from 44 million to 66 million individuals. Uninsured rates also rose 37%, from 36 million to 50 million between 2000 and 2010. Now, this trend was seen in nearly every state. 7 states actually increased their Medicaid rolls by more than 75%. Most states experienced declines in their employer-sponsored insurance as well. And those with the sharpest declines also had some of the highest growth in their Medicaid programs. For example, Michigan, employer-sponsored insurance in Michigan dropped from 73% to 61% of residents in this decade. And over the same time period, its Medicaid enrollment grew from 14% to 23% of the population, and the uninsurance rate increased from 8% to 13%. So looking ahead, especially in light of the Affordable Care Act and expansion, just what do we expect, when we recreate this graph, when we have more recent, more up-to-date data, we expect the Medicaid line to grow. We'd probably have a new line that we build in here to account for insurance purchased through the exchanges, and potentially a reduction in directly purchased insurance, and of course fewer uninsured. So Medicaid enrollment is one of the key determinants of Medicaid spending. And if we try to kind of correct or adjust for this enrollment growth and just look at spending per enrollee, we see kind of a very different story in terms of growth in spending. Medicaid spending has, on a per enrollee basis, remained pretty stable over the last decade, increasing by only 5% over the entire 10-year period after we adjust for inflation. To give you some context, overall healthcare spending in the United States per person increased by 40%, 39% over the same time period. And not all states followed this trend in Medicaid. We saw that state spending per enrollee actually decreased over the last decade in 18 states, and increased by 40% or more in the 5 states, in about 5 states. And some of this variation is due to the composition of the enrollees in a state's Medicaid program. So I'm hoping you've seen a similar graph like this over the last couple of days, but what we spend on Medicaid is driven not only by the number of individuals in each program, but also the mix of enrollees that are covered. A huge proportion, as you can see here, a huge proportion of Medicaid enrollees are parents and kids. This is a relatively inexpensive population to provide coverage for. The cost of covering parents and kids is about 6 times lower than covering elderly and disabled individuals. And elderly and disabled individuals tend to have more complex healthcare needs, costly acute care, long-term care services, and such. And nationally, the elderly and disabled individuals, while they only make up 24% of the Medicaid enrollment, they account for nearly 64% of all payments for services. And the composition of Medicaid enrollees varies by state. States whose Medicaid rolls include more elderly and disabled individuals will tend to have higher average per enrollee spending. And the variation in composition can be driven by many things. For example, the health and demographic mix of the state's population, state-determined Medicaid eligibility thresholds, and just state priorities. For example, in Maine, we saw that Maine had the highest percentage of elderly and disabled enrollees in its Medicaid program compared to any other state. It also had the 3rd highest percentage of residents who are elderly, nearly 10% of whom were under the poverty level. Furthermore, the state's HHS commissioner had said, as part of the debate around Medicaid expansion earlier this year, that the state is prioritizing elderly and disabled individuals in its social services programs. So of course, in the states that are expanding Medicaid to childless adults, that are marked by asterisks, I don't know if they're big enough to see on the projector here, the proportion of elderly and disabled enrollees will decline. The CBO projects that by 2024, 21% of enrollees will be elderly and disabled, down from our 2010 projection or estimates of 24%. So, as you know, Medicaid is jointly funded by federal and state funds. So I'm going to switch gears to focus only on the state dollars flowing into the program for a minute. In 2012, states spent a total of $181 billion of their own funds on their Medicaid programs. To put this into context, we examined state spending on Medicaid as a proportion of states' own source revenue, really to get a sense of what share of the pie is getting spent on Medicaid. In 2012, we saw that state Medicaid spending amounts to 16% of states' own source revenue. And of course, there's great variation across the states, ranging from 5% in North Dakota and Alaska to 26% in New York. And this variation is attributable not only to state Medicaid policy decisions, things such as the breadth of benefits that are covered and which populations are eligible and provider payment rates, but also tax policy decisions and other decisions that determine the size of states' own source revenues. Variation is also driven by factors that are outside of the immediate control of policymakers, such as the state's economic performance overall, demographics and health factors, and regional differences in the cost of providing healthcare services. Just a couple of examples. Am I still on that one? As a percentage of own source revenues, New York and Massachusetts Medicaid spending is among the highest in the nation. These states also have among the highest Medicaid enrollment rates. Over a quarter of their state's populations are enrolled in the program. They also have relatively generous Medicaid benefit packages, very high cost of healthcare services, and the lowest federal matching rates at 50%. In contrast, North Dakota and Alaska have the highest own source revenue per resident in the country, and this is largely due to energy-related income, which makes Medicaid spending a smaller share of their total revenues. Between 2000 and 2012, state spending on Medicaid nationwide increased from about $89 billion, or 12% of own source revenues, to 16%, or $181 billion. Most of this growth occurred in the wake of economic downturns, during which times unemployment soared, state revenues shrank, and Medicaid enrollment increased. We see a couple of dips in this graph. One in 2006, where Medicare started covering prescription drugs for dual eligibles, and in 2009, when because of ARA, the federal government started covering or had an enhanced matching rate for the Medicaid program. So we see a dip again starting in 2009, but as the enhanced FMAP was phased out, but enrollment in Medicaid stayed high, you see this graph going right back up. So looking ahead, our Medicaid report highlights baseline historical data and trends in Medicaid. And we know that there are a lot of changes coming down the pipeline. Medicaid expansion is already driving increases in enrollment, and we don't see it in the data we're showing because of data lags. But we do expect total program costs to rise as we increase coverage. But the federal government will pick up most of this tab for the newly eligible enrollees. Uninsurance rates will drop as we see increased coverage through Medicaid and CHIP and the exchanges. And the CBO estimates that the Affordable Care Act will result in 26 million fewer uninsured through 2024 compared to if we didn't have any health reform. And because of the reduction in uninsured, hospitals expect to incur lower uncompensated care costs. Medicaid's DISH payments, which are designated to offset uncompensated care costs, will decline accordingly starting in 2016. Now, the effects are going to be different depending on states that are expanding and states that are not. So we'll see how that all unfolds. Another change that we expect is that the composition of enrollees in expanding states will change significantly, and the increases will be amongst the lower cost enrollment types, namely the newly eligible adults. And we're also going to see new streamlined enrollment processes across Medicaid, CHIP, and exchanges, and the more understandable income eligibility criteria should also impact Medicaid enrollment. So as states continue implementing the Affordable Care Act, and variation across state programs will definitely increase, continue. And our project will continue to build upon this baseline data that I've shared and track changes in Medicaid enrollment and spending as the rollout of the new health law continues. So I hope that you visit our project website and check out our full report on Medicaid, and all the state level data is available there. Should be available, well, next week, hopefully. And we're also publishing at the same time a report on health indicators, which really provides context. We we thought you couldn't look at spending without looking at the health of the population and different factors like poverty level and things like that. So please visit our website for those 2 reports, and over the course of the summer we'll be publishing the other 6 reports in the series on healthcare spending. Thank you so much.
Want me to start?
Sure.
Okay, is my...
Now it comes the test.
while we're waiting for the
Passed
computer
it
to catch up.
yesterday. I don't know about
It's
today.
okay. It'll get worked out. I'm Leighton Koo. I'm a professor at George Washington University. First of all, what I'd like to say is thank you for coming to this. As state legislators, I believe Medicaid is a terribly important program. I'll say, however, from a state legislator perspective, Medicaid's a big pain in the neck. And so you have volunteered to sort of try to gain some expertise in one of the more complicated programs that exist within the state. One which these days has become more politicized and more visible than ever because of a lot of the fights regarding expansion. It's a complicated program. I guarantee you that no matter what sort of proposals you make, your decisions you make, you will have all sorts of people in your state upset, coming at you, telling you why you're doing the wrong thing. And obviously you do need to do some things, and so keep up the good work, try to make it work, and you're brave people, and so thank you for that. I'm a professor. I've decided, you've been here for, a couple of days already, so you passed Medicaid 101, Medicaid 201, so I call this Medicaid 301. And by the way, that big picture in there, we recently moved. This is our new shiny office building, and then those people on the exercise bikes, that's not me. Next slide. So just to start off with where I'm coming from, with the elephant in the room, as it were, the Affordable Care Act. And so whether you like it or not, the Affordable Care Act is here, and it's here to stay. So far we know already in the exchanges there have been 8 million people, more than 8 million people enrolled. Medicaid enrolled about 6 million more people over the past year or so. This included growth in Medicaid not only in the expanding states but in the non-expanding states. So in almost every state, Medicaid has been growing. On the other hand, there's some good things. We also heard just recently, yesterday I saw a report from the state of Colorado, which was saying that they now have evidence that uncompensated care costs for hospitals have begun to shrink as more people have health insurance, that therefore the number of people who are coming in and requiring care as uninsured people has been going down. So that's saving money for public hospitals and things like that. And this is probably true across the country. We would expect that to be true. Again, even if you have some deep concerns about the ACA or Obamacare, there's already been 1 open enrollment. There will be 3 more open enrollments until the end of the Obama administration. I think, effectively speaking, the Affordable Care Act is here to stay. The question is, however, is it working well, and is it working perfectly? And I will have to accept, as someone who likes the Affordable Care Act, that it's not working perfectly. There are changes that are needed. However, the problem, as I'm sure all of you know, is that there's been particularly on a lot of things related to the Affordable Care Act, gridlock. There are some who basically have said we just want to repeal the Affordable Care Act, and there are others who say we're therefore sort of forced to say, no, we must defend it exactly as it is. And of course, neither is the optimal solution. The optimal solution is actually, we need to make some changes. I'm not going to say necessarily what changes there are, but we need to figure out a way to move forward and accept what it is and try to figure out, can we make it be something that works on balance better. So as state legislators, that's something that I hope you will do, working within your states or encouraging your federal counterparts to try to think of ways, can we come up with bipartisan ways to move forward so we're not stuck? Because right now we're stuck and we need to try to sort of fix some stuff. Next slide. So some of the issues that I think, and I don't know, maybe some of these you've already heard about, but are some important issues that are coming up as a result of the Affordable Care Act that, if they're not dealt with, are going to have a big impact on states. So one is the Affordable Care Act said, gee, we don't have enough primary care doctors in general in the U.S. You may or may not know this. 60 million people in the U.S. live in what's called a health professional or primary care shortage area. meaning that about a fifth of the population in the U.S. lives in areas where there are not enough doctors. And because of this, there's a serious problem in access to care. This problem is expected to grow, largely because of demographics, the aging of the population. I'm a baby boomer. I can swear from my own body that as you get older, you sort of need a little more help. In addition, there are the insurance expansions that add to this. So the Affordable Care Act said we're going to increase how much we pay primary care doctors and Medicaid to come up to the Medicare payment level. And the federal government was going to pick up the tab for that increase. That expires at the end of 2014. And so if that expires, then states are going to have to decide, do we want to keep the payment rates higher, but then we need to pay for a portion of that. The federal government will still match it. Or we need to lower the primary care payment rates, in which case we'll have a lot of doctors mad at us, and conceivably a lot of doctors won't see Medicaid patients. So that's a tough choice. Next issue coming up. Just yesterday we released a paper talking about there's a funding cliff for community health centers. How many of you all know what community health centers are? Oh, good. So community health centers are nonprofit, private healthcare organizations. They're trying to provide primary care in medically underserved communities. They're do-gooder organizations that try to serve vulnerable patients, in rural areas, urban areas alike. The Affordable Care Act, once again, anticipating a problem with primary care, said we're going to sort of add in extra money to support community health centers. That money expires at the end of fiscal year 2015. So the net result is that there's a funding cliff that follows after that. If the funding that was brought in by these so-called mandatory funds is not replaced in some manner, shape, or form, then in that case, we're going to see a big plummet. Our estimates were actually caseload, we'll see about a 7 million person drop in the number of people who are served by community health centers over the next few years, but that money is not dropped. To give you a sense, 7 million, that's like the population of Arizona, or the population of Los Angeles and Houston put together. So this is a big reduction. This is a quarter of the people who are served in community health centers. So once again, this is one of these issues. If the federal money drops out, then people will turn to the states and say, hey, can you put up a share? And maybe some of you will, maybe some of you won't, I don't know. But again, it's one of these things that if that federal situation occurs, then the responsibilities, sort of people will start looking at you guys. Next situation. The Children's Health Insurance Program has been a very popular program in most states. Funding for that program currently is set to expire also after 2015. I think most people think it will be renewed. On the other hand, once again, there'll need to be sort of sources on how are we going to pay for this, how are we going to sustain this. And if the funding for the Children's Health Insurance Program from the federal government dies off, states will be left with a couple of choices. One is shift these children into the Medicaid program instead. Medicaid has a much lower matching rate than the CHIP program. So it'll be a little more expensive to cover those same kids in Medicaid from the state perspective than in CHIP. So that's a problem. Or you cut the kids off. That's also a possibility that exists, or whatever. There are other creative ways of dealing with these issues, but it's a problem that will fall onto states. Now, the fourth area, I suspect you have heard this come up a lot. Kavita just mentioned it a little bit. The Medicaid disproportionate share hospital payment cuts begin after September 2016. How many of you all know what the disproportionate share hospital program is? So this is a little less known. The disproportionate share hospital program, an awful name, is a special way of funding hospitals that serve a disproportionate share of Medicaid and uninsured patients. That's why it's called disproportionate share. What happens is states have often been, shall we say, creative in how they fund the disproportionate share hospital payment program. In many cases, they figured out, we can ask the hospitals or the counties in which these hospitals reside to pay for a portion of this. We'll send this money to the federal government. The federal government will give us our match. Essentially, it's a way for governors squeezing out a little bit of extra flexibility in the money, in which they can sort of then dispense thoughtfully about how to, which hospitals and how to keep extra money that is not coming from state coffers to pay for their Medicaid program. These funds are also supposed to not expire, but to be greatly reduced. The Obama administration has shifted, and not just the administration, Congress too, has shifted back the date at which the dish payment cuts are supposed to begin. On the other hand, by shifting it back, it means the amount that they have to be cut when the cuts actually begin is deeper. So there could be, once again, a problem that could mean that safety net hospitals in your areas could experience some serious problems come fiscal 2017. But more important, that little bit of funding flexibility that states get right now through disproportionate shared hospital payments, the extent to which they can effectively shift some cost onto the federal government, that disappears too. And that'll take a bigger hole from your state budgets. So again, I want to make sure you guys are aware of this. Next slide. So this is a slide actually very similar to what Kavita just made, and you may have seen this before. And the big deal point that I want to make of this is from thinking from a policy perspective. Elderly and disabled are a minority of enrollees, but the great majority of the cost. You will find people frequently come to you and say, gee, we have ways to retool the medical care system so it can be a little more efficient, sort of save some money, whether it works or not. Mostly these are changes that are proposed that will affect children and non-elderly adults. That's not where the money is. The money lies with the elderly and disabled. So if you really want to try to figure out a way to get a hold on Medicaid expenditures in your state, what you need to get a grasp on is how are we going to control costs for the elderly and disabled. So what I would hope that when people come to talk to you about ideas or during legislative sessions, you say, so hold on, what are we going to do about sort of, on one hand, containing costs for the elderly and disabled in Medicaid. This includes long-term care costs. But at the same time, these are very vulnerable people, people who have serious health problems. If you squeeze too hard, you may actually compromise health care for very vulnerable people. There really could be deaths if you compromise their care. So it's a careful balancing act. It's a little hard to figure out what the best routes are. One of the things I think someone from CMS was here yesterday, Ido Bana, was talking about some of their new efforts to coordinate care between Medicaid and Medicare for dual eligibles, the people who are eligible for both Medicaid and Medicare. This is vitally important. This is stuff the federal government should have been doing 15 years ago. I'm sort of embarrassed that it has taken this long for the federal government to get to this point. But anyway, they're there and trying to say, can we set up ways of aligning Medicaid and Medicare so we are making care consistent, effective, and efficient for these extremely important people. So this is something to keep a watch on. I can't honestly say, because it's new, that people know how it's going to turn out. But for the states that are involved in this coordinated care effort, this is the big ticket issue that people ought to care about and what's going to happen from a budget perspective on Medicaid. Next slide. So next I wanted to talk about some win-wins, as I call it, ways that conceivably, and there's good evidence, so this is not just making up off the top of my head. Maybe a little, but there's good evidence about ways you can improve health and save money. So the first thing was something that Deb asked me to talk about specifically. So we looked at a tobacco cessation program in the state of Massachusetts. All states are able to cover smoking cessation benefits, like the nicotine gum, Chantix, some other various medications, tobacco counseling, self-cessation counseling. All states have the ability to cover this in Medicaid. What happens is in many cases they don't promote it very hard. So patients don't know it's available, doctors don't know that it's available. So consequently, not a lot of people use these smoking cessation benefits. But sad to say, the low-income patients, who are the dominant patients in Medicaid, have a terribly high smoking rate. So if you can reduce smoking rates in Medicaid, you can actually have a big public health impact. Now what we did in this study was we looked at some short-term consequences of really trying to push smoking cessation. And what we found was that we could show evidence in Massachusetts that smoking rates fell among Medicaid participants. In addition, hospitalization rates for cardiovascular events, things like heart attacks and stuff like that, fell. Now, so the punchline is really, so as a result, what happened when we did sort of the cost-benefit analysis of this, the state saved $3 in Medicaid costs for every dollar that was invested. So for the extra money that was spent on Medicaid drugs, Medicaid counseling, et cetera, For every dollar spent, they save $3. Now, one of the things many of you may be thinking is smoking cessation is tough. Lots of people stop smoking and then start up again. I mean, let's face it. And this is true. And so I'm not going to say that smoking cessation and Medicaid or that in any way there's an easy cure. It is an addiction. It is tough. On the other hand, what happens is that even short-term efforts for people to reduce or stop their smoking actually lead to fairly rapid improvements in cardiovascular health. Certain things like if you want to prevent lung cancer, emphysema, people need to be off smoking for a fairly protracted period to show those health effects. But for things like cardiovascular effects, actually even a relatively brief period in which you've stopped smoking has substantial health improvement effects. So even if you can get people to stop smoking for only 6 months, for whatever period, you still get a health gain. Now what we found was in general, this 3-to-1 ratio that I talked about, this was money that was recouped by the state within 17 months. So this is a short-term savings. Lots of times people say, oh gee, we need to invest money now, maybe we'll gain money 5 years from now, I might not be in office 5 years from now. Think in terms of a time horizon of 1 or 2 years. This is where you can get savings in Medicaid. So the next area for where there's evidence of savings, because I am an academic, I actually give references at the end of it. So there's usually a little one. The next slide has the reference. And actually, better yet, Deb stuck in your packets something that was, I gave a reference, it's the academic mind frame. I gave it a reference to the scientific paper. She had the good sense, we also wrote a policy brief aimed at state legislators and other policymakers. She stuck that paper in your package. So it's back there, you want to look at it. So another area where we know from evidence that there are savings is expanding family planning eligibility in Medicaid. It is possible to expand eligibility for family planning services for women in Medicaid. And so this is not just, this could be low-income women. In many states, they go up to 250% of poverty. This is like $55,000 for a family of 4 sort of income range for family planning services. Why this is important is that we know, and again, there's strong evidence that this is true, that this helps avert unplanned pregnancies, reduce abortions, saves Medicaid costs related to delivery, saves other costs that are associated with unwanted babies in low-income families, helps the families in many cases too. One of the things, there's new evidence coming out that part of the specific effect in Medicaid is there are these things called long-acting reversible contraceptives. So as opposed to the pill, there are certain better methods that are for contraception that are available. So those are things like implants, certain shots that last for a longer time. These have a much higher success rate in terms of avoiding pregnancy. The downside to them is they are more expensive up front. So when you get the pill, your prescription may cost essentially maybe $20, $30 a month for the prescription for the pill. If you get an implant, it may cost a couple $100, but it'll last a long time. Because of this, many people and many clinics that provide these services can't afford the long-acting reversible contraception method. One of the things we know now, there's evidence that when Medicaid has expanded family planning eligibility, because Medicaid will pay this tab, that they can afford those long-acting contraceptives. And this leads to better results as far as contraception and family planning. So again, these are some ways that we know can save money. There's evidence this works. There are things that can help. Third area that I want to mention is support community health centers. And here, this is not within your Medicaid budget, though your Medicaid budget helps pay for community health centers. But in many cases, states also provide additional funding to support community health centers in their state. Why this is important, and once again, this is an area where we've done research. We know that if you can get people who are low-income people who otherwise have difficulty getting access to primary care, they get this primary care. This means that they control their diabetes, they control their asthma, they control their hypertension. What this leads to is reductions in the need for specialty care, emergency room, hospitalization costs. The study that we did basically said that people who use community health centers for care have annual medical expenditures that are 24% lower, 1/4 lower than similar people who aren't getting care at community health centers. So supporting community health centers leads to better health, which also leads to lower expenditures. so you can save money. So these are all some ways that are win-win possibilities within states where you can try to sort of do both helping people out, getting them better care, and at the same time ending up resulting in lower medical expenditures and lower Medicaid costs, which I think is a desire that hopefully everyone can share on a bipartisan basis. That's it. Thank you very much.
Oh, I don't have to. Okay, but thank you. Good morning, everyone. My name is Shelby Gonzalez, not Shelby, just for those of you keeping track. I work for the Center on Budget and Policy Priorities, and the center focuses on a whole range of issues that are very focused on low and moderate income families and ensuring that that they're considered as policy discussions and budget discussions are happening at the state and federal level. I personally, at the center, work at the health team, and my focus is really on eligibility and outreach and enrollment activities into programs for people that have low incomes. So Medicaid and CHIP and certainly all the different coverage opportunities within the Affordable Care Act definitely fall within that umbrella. Kind of going on the theme that we just heard, Leighton talk a little bit about in WINS, I'm going to be focused on talking to you a little bit about two different policy options that are available to your states, where there's really a great opportunity to help improve access to different benefit programs. So the first one I'm going to talk to you a little bit about is an option that we could really use a better name for, but you may have heard about it being talked about as SNAP to Medicaid or fast track enrollment or Strategy 3 or even plopping. So all of those names are terribly not descriptive or informative about how great the option can possibly be for some states. And this option was created, it's a waiver option that states have, but it's not the kind of waiver that many of our states are familiar with that take, weeks and weeks and weeks and months and months and months to get approved. It's actually a specific waiver that some states have been approved in a matter of, of weeks, not necessarily months. It allows states to look at their SNAP caseload. It could also happen with TANF as well, and that, and I'll get back to that in a little bit. But first, thinking about SNAP. So, just for anybody who, I don't know how long you've been in state government, right? It's also known as food stamps. So it's the program for low-income people that provides food assistance. There is a lot of similarity when you think about the people, when you look at that caseload in your SNAP caseload, typically it's individuals with very, very, very low income. SNAP goes all the way up to 130% of gross income potentially, so people still not very high income, but the reality when you look at who participates in SNAP, usually it's people with very, very, very low incomes. This option allows states to look at their SNAP caseload, identify a target audience that they are sure, that they feel very confident will meet the Medicaid income threshold, and in states that have expanded Medicaid, that's a whole lot of people. If they're not elderly or disabled, that's the majority of people. There's very few times where you'd have to take people out because even though the methods, the way that we count income, the way that we count households are different between Medicaid and SNAP, the reality is that that it's very, very, very unlikely that you would find a SNAP participant that's not elderly or disabled that would not qualify under an expanded Medicaid threshold of 138%. So this option allows states to, find a target group and enroll them into this program. The state really only has to do a few things. Of course, they have to get the waiver approved, and in that waiver, they have to outline what their plans are to make this happen, how they would target their audience, how they would ensure that that the individuals that would be targeted for this type of enrollment into Medicaid want to be enrolled. They have to capture some type of consent to make sure that this is an individual who wants to sign up for this benefit. They have to make sure that the individuals know their rights and responsibilities, because there are a lot of those when you're going to be covered by Medicaid. They also have to, if there are other eligibility factors that can't be, or that are done a little bit differently in SNAP, they would have to go ahead and find a way, a mechanism to ensure that that is verified in another way. So, for example, SNAP verifies citizenship slightly different than how Medicaid does. So Medicaid, in this option, could run an electronic match with the Social Security Administration to take care of that. So there's a lot of things, steps that can happen in the background, and that your Medicaid directors are very, very knowledgeable about those kind of steps. So it's a very fast-track way of not requiring that the same individual, the same SNAP participant that has already gone through a very lengthy process in terms of providing a lot of information about themselves and their circumstances, as well as proof of their income. And for SNAP, you have to prove your circumstances every 6 months. So the information in the SNAP caseload is always current. It's very, very current, and it's rigorously evaluated. And because it's rigorously evaluated, it is, it's time-consuming for state workers. So this not only is a reduction in duplication of efforts for the consumer, who would not have to go through two, while we're striving towards a more streamlined application process for Medicaid, it's still difficult for many, many consumers. Still paper heavy. There's still a lot of proof that has to happen. It's that exists as well in SNAP to make sure that there's program integrity for both programs. But if you've already done it, the state workers, and you've already invested that kind of rigor, in terms of an evaluation of somebody's eligibility, you can find some efficiency in not having to duplicate it again for people who are now going to become eligible for Medicaid. By taking the information and saying that if it was rigor, if it's good enough for SNAP, it's good enough for Medicaid. So there's this option, which so far only 5 states have begun implementing the option, but it's been impressive in terms of the results. Over 500,000 people have been able to be determined in this way. So we think that there's a lot of opportunity for more states to be considering the use of this option. And while it sounds like it's something that could only potentially work in a state that has expanded Medicaid, there is some options, because as I mentioned beforehand, you can really target your audience, right? So for example, in a state that hasn't expanded Medicaid, they could say we're only going to take, people who have a gross income of 30% of the federal poverty line, if that's what's relevant to your, So there's a way to target your audience so that it's relevant, and certainly kids who could also go, use a similar option, but there are the parents who would still qualify. You could target it so that it matches your income level for those states. So that's one option that I wanted to talk a little bit about. The second option I wanted to mention is the opportunity for an enhanced match, a federal match for the build-out of eligibility systems. And you may have heard of us, a lot of people talking about it as a 90-10, where the federal government is putting up 90% of the resources and the state government is putting up 10% of the resources to build more modernized systems, eligibility systems. This was an opportunity provided to the states, now several years ago. And the states that do implement those, there are very specific criteria that states must meet in terms of to be able to get this enhanced match. And most states have begun drawing down that enhanced match to a certain degree. But it is also available so that states can be maximizing some of this new technology in their eligibility systems. And I should back up for a second. The reason why this is so important to us and when we get excited about this opportunity is because most states have had years and years and years of using eligibility systems that we like to call, the legacy systems that are dinosaurs. And sometimes it involve the necessity of having an individual who still knows how to use specific kind of programming that every day becomes less and less likely that you're going to find someone that's going to have that expertise, and that are very rigid and difficult to work with. The 90-10 was really an opportunity to have, most of the time states are drawing down about 50-50 match for these kind of systems, and it's expensive to create these systems. So there's this great opportunity that states were given to either update their systems or to develop new systems so that they can improve the efficiency of their eligibility systems. And then those who met those criteria and developed their systems according to the criteria that CMS set forth would then be eligible for a 75% match, which again is higher than the normal match of about 50%, for ongoing maintenance of the systems. And they're eligible, and that maintenance includes things like eligibility staff that work in those systems. So it's a huge potential for for helping state budgets and county budgets, as a matter of fact, as well, depending on how you implement your programs. And there, in addition to this 90 and 75 match, there is a potential for states to kind of maximize this opportunity for other benefit programs. Because if you think about how the states implement in most states, if you go to one place, it's the same eligibility worker that's determining your eligibility for SNAP, TANF, Medicaid, you name it. Oftentimes, what would happen is when you would build out a new eligibility system, the cost allocation is fairly rigid in how you have to allocate between all of those programs a system build. Certain aspects of this system build, there's been a waiver of traditional cost allocation, so there's an opportunity to also maximize when the system, the fundamentals of the system that are applicable to all of the programs. Now, if you want to do something that's separate and different for just SNAP, then that you're going to get your traditional match. But for the actual system functions that are going to be helping all of the programs, that can get this enhanced match as well. So there's this great opportunity. We know that states have begun, they've been tapping into the enhanced match to a certain degree, but there is opportunity to make sure and find out if your states are maximizing that opportunity, and that it is pretty important because there is this ends. This is time limited. It's going to be at the end of 2015. The states must have incurred the expenses to build these systems. So it's very timely. It's important that states think very strategically about how they invest these dollars now, so that they can really maximize and improve how they deliver their systems, so they can find some new efficiencies moving forward. So with that,
Hi. I'm going to try and keep my remarks relatively short so we can move into Q&A because we've been talking for a while. My name is Matt Hoffman. I am a health budget analyst for the House Budget Committee under Chairman Paul Ryan. And on Medicaid, I'm basically going to talk about three areas. One, spending, and how the federal government looks at Medicaid. Two, access. That's really the two major components when it comes to Medicaid that we look at. And then three, I'm going to highlight one area that I think, as far as the federal government is concerned, when it comes to Medicaid, you all should keep on your radars. As spending goes, we tend to look at Medicaid spending in the aggregate. We don't really focus on how much each state gets as a federal match, primarily because of the way that the matching program is set in law. It's a formula that spits out what each state gets, and it basically measures a state per capita income relative to the rest of the United States, and then adjusts that such that lower income states get a higher basic match, and then it basically averages out. Over the time that the program's been up, it's been a fairly narrow band on average between about 58, 59, and 61. With some states, Alaska, for example, getting a much higher rate, and other states getting a more closer to 50%. For the federal budget, we have seen a dramatic growth in Medicaid, partly because as recessions go up, the growth on a year-to-year basis goes up significantly, and as the economy gets better, the rate of growth, I'm going to be careful here, the rate of growth actually decreases. That said, every year on a year-to-year basis, dramatically the spending has gone up. And most recently, our next, the CBO projections have us on an average year-to-year basis of about 8%. Some context, our economy grows recently at about between 1% and 2%. When we look at Medicare, which is our second major health federal entitlement, that's going to grow about 6%. Then we look at Social Security, and we add an interest in the debt, and by the mid-2020s, a little later, the entire federal budget is essentially going to be consumed by these programs. When you look at the revenue coming in, we basically have three options. We can cut benefits, we can raise taxes, or we continue borrowing. Some combination of the three, but those are our basic options. To be fair, when it comes to the ACA, this was largely true before we passed the healthcare law. Now that we've added a new entitlement, it has simply moved up the date in which these things will happen. So from a federal perspective, we are looking at ways to constrain spending. So a lot of the things that we talked about earlier in terms of dates when certain things will expire or when authorizations won't occur, the debate around those things tends to go into two directions. One, the necessity of having these programs around and the benefits they provide, and how do we provide those benefits such that we are protecting the fiscal nature that comes along with them. We can get into which program and how and ideas through Q&A, but that's the federal perspective of which we look at it. On access, this is the the flip side of the coin on spending. We've talked about how Medicaid on a per-person spending in the four groups is relatively flat or low compared to other spending. And this is largely true, but that's because of the payment rates that go along with the program. If we look at what Medicaid provides physicians and providers compared to what's available on private insurer sides, it's about 71 cents on the dollar. On Medicare, it's about 88 cents on the dollar. And because of a lot of the payment adjustments that were made in the healthcare law, those are going to drive significantly lower into the future. I think by 2019, about 15% of hospitals, home health, hospice, SNFs will be in, quote, they will be in the negative, or they'll have negative margins, bankrupt, however you want to describe it. They will not be able to continue operations as they currently are. So the question becomes, how do we continue operating these programs and providing coverage while at the same time we can't provide the services on the back end? And how do we have that adjustment between state governments and the federal government such that these programs can work? Because there is an agreement, I think, on both sides of the aisle that these safety net programs are vital to helping us move forward as a nation. So again, those access problems are real. These are from the Medicare and Medicaid trustees, and CBO is basically what the budget committee uses to sort of look at these programs. And we try to measure our reforms or ideas against those baselines and see what they say in terms of a policy will have on both impact on spending and, again, access. And sort of the last thing I want to highlight when it comes to Medicaid for states, along with all the other things you heard, is simply this the 100% match rate you've heard for the newly eligible populations. That is true up until 2016. And then beginning in 2017 through 2020, that 100% match rate drops to 90. I think it goes like 95 and then 94, 92 down to 90. This is a dramatic, two things I want to point out. One, this is a dramatic change in the way that Medicaid reimbursements have been done. and on a philosophical level. Remember I talked about earlier that federal payments to states are based on a statutory formula. We don't, the formula and the program is not intended to dictate to each state what they will get, or the federal government is not supposed to dictate to states, here is what you each will get based on political wrangling. It's here's the formula on income, adjusted for income as the way states are, and then that'll determine it. We now have in statute set percentage payments that states will get for their new populations, which adds a whole new dynamic to the way that the federal government is going to look at spending when it comes to states and newly eligible populations. Secondly, the DISH, or the FMAP, that's the Federal Medical Assistance Percentage, that's what the federal government determines, that's the name of their formula. That has again changed. It's been expanded. We've added things to it. We've taken away to it. When there's disasters, when we think of the stimulus, we've expanded it, and then it's contracted. There is nothing to suggest, or let's put it this way. Current Congresses cannot bind the hands of future Congresses. Just because the formula, or in law it says that the payment will drop from 100% to 95% in 2017, does not mean that it won't drop to 90% or 92%, or that we simply hold those lines through 2020. You can look back at recent examples of other DISH payments we've changed. You can look at the sequester and that debate and how that all changed. And we did it, then we didn't do it, and then we passed a budget agreement for the first time in a decade, which we were very excited about in the budget committee. But moving again, I want to put that on your radar as you start planning for the future, that there is a new cost that states will incur for this expanded population, and it's on the horizon. It will occur after 2016. And then it does phase down to 90%. And there's nothing that guarantees that those levels will be hit. So just those three things. Happy to take questions, and thanks for coming, having me.
All right, thank you very much. I did some quick little, just a minute, did some quick little math here, and it seems to me, at least during our time here, I get 3, 5, 6, 7, 8, at least 9 things that have been recommended that you all can go home to your state and look at to save money within the Medicaid program outside of anything that has to do with the ACA and expansion. Layton gave you 3, Shelby gave you 2, we heard about 2 in corrections, we heard about enhanced match with medical homes, and then we've heard a big warning here at the very end about, but be careful be careful, because the future's coming and the crystal ball's kind of foggy. So gives us lots to think about. I thank you very much. And now we'll open the floor to questions. Paul's always the first one to jump on.
Hi, I'm from Arizona. Does the ACA have any impact on GME funding to states? And either way, do you see a decrease in graduate medical education funding to states in the future? Or any, anything you can answer, please.
I forget whether there were changes in GME in the ACA. I don't remember them off the top of my head, but certainly GME, for those of you who don't know, is typically people mean that Medicare pays a certain amount to teaching hospitals to pay for the training of residents and interns, so the people who graduate from medical school, they do a residency. So there's a somewhat odd formula that is used to generate how much is paid for GME. Many states, but not all states, also have a Medicaid GME program that is not based on federal law, so that's entirely up to states. So there's a lot of pressure to reduce GME payments. There have been some studies basically that say that the amount of GME, and then there's something comparable, in fact this is actually the one that gets criticized a little more, called IME, indirect medical education payments, that are sort of the indirect costs related to GME. That suggests that the federal rate of payment for those things is too high. And if that's true, then these payment rates may go down, which teaching hospitals would be very upset about, and may cause some problems in the training of physicians. I'll say there's an interesting alternative which the ACA does specifically set up, called teaching health centers. And this is sort of a pilot project in which the concept is, gee, what we really need are primary care doctors throughout the ambulatory area, why is it that we're training people on how to work in hospitals when we'd rather have them out in the field? So the teaching health center model is basically say, why don't we permit graduate medical expenditures, in this case actually not paid out of Medicare, but paid out of HRSA funding to sort of help fund residencies in this area. This is a new pilot program being tried out in a variety of areas. I think it's sort of a fascinating concept, this concept that you can train people to work in ambulatory settings, and in addition, in health centers where they're sort of dedicated to primary care for vulnerable populations. So not quite an answer here.
Okay. Real quick follow-up. Matt, do you foresee the pre-existing condition program, shouldering the burden, falling to states either directly or indirectly?
You're talking about the risk pool?
Yes.
Yeah. There has been, so it was extended. It ran a shortfall the first time that they did an anti-close open enrollment. I think that there's going to be a lot of discussion between states and HHS on that. Some states have their own risk pool that they're just fine. Some states, they have, Wisconsin, for example, they won't extend it. They had a decent sized enrollment on it. I do think it's going to wind up being a state-by-state issue. I do believe it's going to wind up on the discretionary side. So my guess is you're going to wind up having a year-by-year fight over what happens with that fund. It's not going to be here's a continual stream of money that the HHS, the agency, would have to pay.
I would like to ask you to kind of expand a little bit further on your Massachusetts experience, because I'm from Kentucky. We have a very unhealthy population. We have a high smoking rate, high obesity rate, diabetes. So there's real opportunities there to save money if we kind of enforce healthier policies. But from a private perspective, if I'm a smoker, then my rates go up. But if you're within the Medicaid program and you smoke, you can be encouraged not to, but there's really nothing that prohibits you from smoking. So can you, in Massachusetts, how did you all do that? How did you increase those rates of non-smokers or people that took advantage of it? Was there any kind of punitive thing that was imposed, or was it just an encouragement?
It was really an encouragement, and part of the reason why people are generally not, and so, in fact, under the Affordable Care Act, now there are these so-called essential health benefits that must be offered by virtually all health insurance, including private insurance. And some of these quote-unquote essential health benefits include preventive benefits, and one of the preventive benefits is smoking cessation. The problem with why these benefits tend to be underused is A, people are often not aware of it. And in addition, when people think about smoking cessation, in many cases they think of things like Nicorette and so on and so forth. Those are typically sold over the counter. And because they're done as an over-the-counter benefit, as opposed to a prescription, people often think, well, my medical insurance doesn't cover that. And my doctor never talks about it. I mean, typically, if you go to a doctor, your doctor might say, I don't know, you should stop smoking. And while you're at it, lose 15 pounds. And that's about it. So they're not providing the full pathways that they could do, with just a few words more to say, and I could write a prescription for this smoking cessation benefit for you, and their medications like Chantix or I don't remember the medical name, but anyway, that are quite effective in terms of reducing smoking as well as providing counseling. So that was the main thing that they did in Massachusetts. They really made sure that patients knew about it, doctors knew about it, that the insurance companies in many cases knew about it. I mean, this is another problem. In fact, in many cases, it was covered as a benefit. But if a doctor would go to the insurance company saying, "Is this covered?" The insurance would say, "Hell no." And it wasn't covered. It was under their contracts. Just the person they called didn't know because it sort of was an obscure benefit. So it was really as much as that, sort of really pushing public information. There were no sticks involved that I'm aware of, but surveys traditionally show that most people who are smokers actually do want to smoke. Do want to stop smoking, but they realize it's hard. So it's providing these opportunities to sort of make it easy for them to do so with something, and again, in Medicaid, that they don't need to sort of pay for out of pocket. That makes it much easier to take it up. And again, it's not always going to work as a long-term thing, and some people might not even stop at all. You know, it's one of these things that does not always work perfectly. Nonetheless, it's a percentage game, and you get enough people to stop smoking for enough time that their health gains and their health benefits. So other states have begun to take this up. Actually, in Massachusetts, last that I was hearing, they were trying to do something to sort of push this as far as private insurance in the state of Massachusetts. Also, is anyone from Massachusetts here? Did anything like that happen?
Trying.
Okay, so there have been efforts, you know, to sort of say, gee, you know, there could be private insurance gains for this too.
We just had the Smoking Success Program. Most towns now in Massachusetts are moving to an age of 21 to buy tobacco, and we've also increased the taxes significantly. The cigarettes are now about $11 in Massachusetts. And so it's not just the cessation, it's the prevention of more smokers, and it's not just the revenue you see from the taxes, it's the future health savings that are really protect the real high dollar savings in Massachusetts.
And that's absolutely true. If you really want to reduce smoking, as I said, you need a multi-pronged approach. So there are all sorts of ways to do that. There's a well-developed toolkit and lots of evidence that some of these things, like raising cigarette taxes, public, you know, having smoking restrictions on public smoking in workplaces and so on, that these are effective. Again, not everything's not perfect, but you know, you get a good solid game.
Did you have a question, April?
I'm from the state of Alabama, and one of the issues that we have, especially
Can you speak up a little? We're having trouble.
we've had a problem with providers, people who have Medicaid having access to providers, especially in our rural areas.
My question is about providers in rural areas for Medicaid population. So if we have,
Speak louder. If we have cuts in our program funding, like the residency programs and that sort of thing, what do you see coming down from the feds as they look at us and we don't have the providers in place to take care of the Medicaid population?
So this speaks to sort of the way in which, the other way that we look at federal funding, right? So I think, the last survey I saw has every state now using provider cuts as a way of managing their Medicaid budgets. So people are looking for ways to cut Medicaid costs, and especially as more and more people go in the program, the services expand. When the utilization of services expand, costs are going to go up. There are a list of benefits that are currently mandated for having a second Medicaid program, and then there's some optional benefits. But we're already seeing, but this was true before the ACA. We had access problems in Medicaid well before, and it's been going on for years, and it has to do with the underpayments relative to what the private sector offers when it comes to participation. Right? So dentistry is a great example, especially in the lower eastern states. Having a dentist, you can find one for several thousand miles or something for the state. But again, because of the way the Medicaid is a federal state program, states tend to submit to HHS what their programs are going to be, and then determine at the state level what their reimbursement levels are. And we heard earlier about how there was the primary care bump up mechanism. Again, all of those things add to the total spend, which at the end of the day are driving larger budget problems. We have tried to address them. One of the problems would be at the federal level is we've now gotten to the point where entitlement reform, and I speak of Social Security, Medicare, Medicaid, those three, is the way to solve our federal budget problems. We've just ignored that for a very long time. And I don't mean in partisan ways. For decades we have done. Layering new entitlement on top of this has really exacerbated the problem. And the ACA, specifically with Medicaid, there really wasn't much done on fixing the underlying access problems. It was about expanding coverage. So I think for the foreseeable future, we're still going to have access problems. And it is as much a matter of payments as it is changing the way that Medicaid works. What we look at on both sides of the aisle is cutting a lot of strings in terms of receiving federal payments and letting states design their programs What we've seen, it used to be the Section 115 or 1115 waivers, and Indiana just got theirs, and people are going to look to see. I'd be curious to hear, there are Indiana folks here? I'd be curious to hear from you sort of over the next few months and years how this new reform works in your state. There was a push years ago to get more 115. I think Rhode Island had a phenomenal example of waivers working in their states. So that's another idea that's been pushed. But until we actually get into the nitty-gritty of Medicaid reform, which is both politically and substantively tough, I think those access problems are going to remain. And it will fall on the states really at the end of the day who are responsible for designing their programs to figure out how they're going to make the dollar.
And what kind of trouble do we get in if we don't have the appropriate provider access?
Okay. That's one of the examples.
So let me start with some basics about sort of what we know about physician participation rates in Medicaid. Every now and then I've heard people say, oh God, no doctors accept Medicaid. The best statistics that we have suggest that about 2/3 of primary care doctors in the U.S. Accept Medicaid patients. It's actually a higher percentage for specialty doctors. Now, that is not necessarily the best comfort when in rural areas there are not enough doctors to begin with to serve, the privately insured as well as the Medicaid population. And so part of the key there really has to do with the fact that there's a maldistribution of doctors. And part of the answer in part has to do with we need more creative ways, both at the federal level and the state level, to try to encourage physicians to practice in underserved areas, and in many cases this means rural areas, and there are lots of ways that states have been trying to do this successfully. Though actually one of the parts that's been most successful is community health centers. Community health centers, because they're designed to be in medically underserved areas, in many cases they've really been linchpins that are sort of become the key providers in their communities. Now the question is, what happens if your state doesn't have enough doctors to serve patients? I'll be honest and say, as far as I know, the federal government has never stepped in at the state level and saying, you're not doing a good enough job. The increase in primary care payment rates was intended to try to sort of increase access to primary care doctors. Now lots of states are turning to managed care. There are provisions where managed care systems are supposed to have so-called network adequacy, and there are ways of testing that. But I'll be honest and say, have I ever heard of a situation where they said, gee, there's only one doctor in the county, and that one doctor, and so we're not going to let you serve anybody because you only have one doctor in your county. That would be kind of stupid. But so that result is the real underlying problem is that there frequently are not enough doctors in primary care communities. Some of the answers that people talk about is, so can you do things like increase the scope of practice so nurse practitioners or other people can provide care. So one of the things we know in community health centers, in a typical doctor's office, there's sort of one doctor, maybe one or two other medical staff, like a nurse or somebody. What happens in community health centers? The ratio goes like 1 to 4. One physician and then 4 other medical practitioners who are there to provide services. So they're really trying to stretch that limited physician resource effectively. So that's part of the key that people are talking about in general on a national level. And again, it's not just for Medicaid. This is a problem for provider access just in general. Again, 1/5 of the country lives in an area that's considered a primary care shortage area. Most of them are rural areas. Some of them are in inner city areas. So this is a big problem.
And if I could add to that, I think there's a lot of lessons to be learned in terms of what prisons are doing. Prisons are often in rural areas, and there's a high cost to taking prisoners out to go see specialists or trying to lure doctors, or lure, wrong word, but attract doctors primary care to come to prisons to treat patients. And so there's been a lot of kind of innovation and experimentation in terms of using telehealth and scope of practice, expanding the scope of what different practitioner types can do, and coupling that with telehealth in order to kind of get better access in rural areas. And granted, that's inside prison walls, but the same lesson I think can be applied. And the other piece is, especially in areas where you're close to a border, a state border, there's rules that are state specific around whether you're able to get reimbursement for a doctor that's on the other side of the state border in the next state over. So that there's implications there that vary state to state based on if you're doing telemedicine with a provider that's in your next state.
Yeah, great discussion. Appreciate it. Leighton, you mentioned.
Could you stand up just so the rest of us can hear? Actually, the noise back there is stopped visible, so that helps some. But
anyway, great panel discussion. Leighton, you mentioned the smoking cessation and the 3-to-1 return on investment. My question is on SNAP, Supplemental Nutritional Assistance Program. The key word nutritional. You can buy energy drinks, candy bars, potato chips, jerky, junk. That's low-hanging fruit. How come there hasn't been anything at the national level to drive policy to make those foodstuffs purchased with food stamps more nutritional? That seems to me the return on investment would be off the chart. But we never hear anything about that. When we bring it up at the state level, as far as a waiver to have that in our state, it is just absolutely dead silence, like somebody just said the wrong thing. What's going on with that?
I'm assuming that's me. I will say that, so with the recent ag bill, there was some SNAP reforms. There tends to be a very big conversation between access to food and what's available, and then how that gets meted out from the regulatory side as well as with the policies. It's an ongoing conversation. We just haven't made the progress that we need to. But I would say that the most recent farm bill was at least a step in the right direction in terms of having a more open conversation about how we reform SNAP.
So from my perspective, this has been an issue that's been, and I'll let you know, I used to work for the Food Nutrition Service a couple of decades ago. This debate goes way back. And so there have been efforts from both conservatives and liberals to say, can't we limit, so we don't pay for junk food or lobster, choose your food in the food stamp or SNAP program. And what happens is typically these have been things that a state or a local area goes to the federal government to, and USDA has to say, in the right when they say this, the law does not permit this. So the question becomes, can the law be changed? And the answer is, there are a couple of issues that come up. One is every time you do these things, there are vested interests who will say, you're talking about sports drinks, but don't we think we want to encourage athletes? And you say sports drinks should be, encouraged, aren't we discouraging sports? And so there are these things. The grocery stores will say, right now all our cash registers in America are set up that food stamps can pay for anything that's a food item. If you say this, we will have to reprogram each and every cash register in all the supermarkets so that they, A, know what's a sports drink versus what is a healthy drink and so on. So there are all sorts of arguments. I agree with the spirit of what you're saying. And in fact, the WIC program has always been set up around the concept of saying we only want to pay for foods that we think are healthy. Nonetheless, this has been a limitation in the food stamp program. Part of it, I'll be honest, is also sort of a paternalism concern of, gee, we're giving this money to tell people buy food. Don't you think if we do this and we now restrict these 6 items, the Cato Institute, for example, will say, well, this is the nanny state getting even bigger in terms of saying, now we're telling people they can't have soda pop.
I will tell you that there's money in your SNAP program in your state to do educational work with families who receive food stamps, and just ask what's going on. I live with a guy who's been involved in that, and it's been very difficult, who comes from the WIC program perspective. They think they know something about educating families on food, and they can't get together with their food stamp people to further that education and to use the money the federal government has made available to help families know more about purchasing, making smarter food purchases. So it's there's a conversation that can be had at your state level maybe to to provide some, which is short of what you're talking about, but it may be, in the meantime, it may be a way to get a little closer.
Well, and my point is, I mean, the food stamp and the relationship to Medicaid, you get healthy foods into that group of people, it's going to have the same kind of returns or more that your smoking cessation.
Sure.
Just makes sense to
sure. I think you were next.
Yeah, so I have two questions, and I hope if that's too many, I'll just get my second one. The first one is in terms of I've heard different things about what you, Matt, you were talking about how the entitlement programs will continue to grow with the ACA. And we've heard about how it's actually self-funding, and that there are at least a couple things, such as reducing Medicare rates, premiums, tax. And so I was just wondering if you could help clarify whether it is in fact self-funded or whether it will ultimately add to the deficit. Especially considering that CPO had a total projection of a deficit reduction. The second thing is much more of a general question to anybody that might know. I know I think states, just like Connecticut, typically will make changes in the Medicaid program every year. And some people, like people in my office, will estimate how much we think it will save or cost. But once the year gets going, we have no way of measuring whether or not any of that happens. So you mentioned cessation 3-to-1. As far as I know, in our case, the data in our system, nobody has the ability to measure anything. It might just be a legacy thing, but that 3-to-1 thing, we could never figure that out in the system that we have. So I'm just throwing that out there in case anybody has any insight.
The first question you asked is a contentious issue. We'll just start by saying that. So we'll start when the law was passed in 2010. CBO has a 10-year projection on how they analyze bills. And the law in 2010, as was written, had Obamacare, ACA, whatever, starting in essentially, when I say starting, what I mean is the coverage provisions, the exchange subsidies, the Medicaid expansion, small business tax credit, and associated other things like the mandate penalty and other revenue generating things. The coverage provisions didn't start until 2014. So a lot of the revenue generating provisions like payroll tax, like it had about 2 dozen tax provisions. Things from extraneous things like a black liquor tax, which is an ethanol-based tax when it comes to energy, to things like economic doctrine, which is a way that companies with international finances tax their books. It had a whole host of revenue provisions that started on a staggered provision, but really started right away. So at the end of the day, when the bill was passed, it had 10 years worth of savings or revenue coming in and cuts to other programs like Medicare, some Medicaid changes as well. But it only had, from 2014 until about 2020, 6 years worth of spending. So in that 10-year window, you had 10 years worth of savings and 4 years worth of spending. So in that window, CBO said, well, this bill, as we look at it, reduces the deficit. Now, the flip side is, CBO also said in the long term projections, this bill will reduce healthcare costs because of a whole host of components of the bill, including coverage expansion and some of the Medicare provisions. Now, I'm going to touch on the Medicare provisions. There were, back in the latest numbers we have, there was about $700 billion in Medicare reductions. And you'll hear these described as these are reduced payments to insurance companies that were overcharging. I won't debate that. It's debatable, but I'll leave that aside for now. It had reductions in payments to providers as well. Both CBO and the chief actuary for Medicare have said that the payment reductions to Medicare beneficiaries, to Medicare providers under the ACA are unsustainable. In other words, as we were talking about earlier when I was saying that Medicare pays providers about 88 cents on the dollar compared to what private payers pay, Medicare under the ACA will now pay, in the next 10, 15 years, will pay below what Medicaid pays to providers. That is how a lot of the savings were achieved within the Medicare program. To be fair, they also did things like value-based purchasing, bundling of payments, a whole host of pilot programs to encourage utilization of care. We talked about coordination of care earlier. CBO did a report on a decade's worth of pilot programs in Medicare that were intended to have the purpose of coordinating care to reduce healthcare costs, and found that very little cost reduction actually occurred in these pilot programs. And in fact, when the CBO director came to testify before the committee recently, last fall, when asked about this, he said, you know, there was a lot of questions about why haven't we gotten enough savings, why haven't you given enough savings or credit to the ACA's pilot programs on reducing healthcare costs? He says, because we're waiting for evidence. We haven't seen anything yet. These pilot programs are up and running, but there's nothing right now to suggest that they will reduce costs. So on paper, according to CBO, that the bill had more revenue and cuts than it did spending projections. But when we look at the nature of what those revenue generations and spending cuts are, they are largely fictional. There are a lot of paper tigers in there. And so, for example, the administration has delayed a lot of the Medicare Advantage plans. There was supposed to be a significant number of cuts starting this year and last year to the plans. That was helped to offset the cost of the ACA. Those cuts have been delayed. We've seen a whole about 30-ish, 39 provisions of an ACA. Most of them targeted to revenue generation, delayed. Employer mandates have been delayed. There's a reporting document that was delayed. So I think and now we are 5 years since the initial debate and since it's been passed. It's hard, CBO has said, well, they can't give you a new fiscal picture of the law. It's 10 years later, and when we look at what the Medicare cuts were in 2009, right, which is 2008 when the law was passed, Medicare had payment rates for providers, and they're based on what the market looks like now, what they project behavior to be, and the law changed the way those payment formulas were composed. We're now 5 years later. It's hard to go back and say, well, in the intervening 5 years, if we didn't have the ACA, how would these payment formulas have changed, or what would the new update be? So CBO has said it is tough for us to give you a full fiscal accounting of what the ACA is under now compared to what it would have been in the absence of the ACA. Because of these, we would have to unwind the clock on a lot of provisions that have already changed behavior. Right? They would have to make a certain set of assumptions that they don't feel comfortable or they don't feel is within their jurisdiction to make. Right? So do we assume that, so let's take SNF for example, would we assume that in the absence of the ACA, skilled nursing facilities, the utilization of those services would have been double what they otherwise are? And it's an assumption you have to make into building these scorekeeping estimates, and they don't feel that it's their call. Absence, so we could write a bill that says to CBO, assume that skilled nursing facilities utilization rates were half or double what they otherwise would have been. And then they could go do that. But as a non-elected body that is simply there to make the green eye shade scorekeepers, it's not within their jurisdiction to make that call. What they will give us, however, is the cost of coverage provisions. And that's the expansions, the subsidies, and then the related revenue provisions to that. And we have seen those grow steadily. We've seen a mix change. So the Medicaid spending has gone up, the exchange spending has gone down a little bit. Some of that has to do with the economy. Some of that has to do with take-up rates. Some of it has to do with insurance costs. But there is a heated debate and a large concern that when the discussion over the bill was it's paid for and it's deficit neutral and reduce the deficit, we now have A, no way of really knowing and checking on that. And B, a lot of the payment provisions have turned out to be paper tigers. That's my take on it. I'm sure there's a healthy debate over it.
So let me try to basically, I agree with lots of what Matt was saying. But first let me say, things like the Congressional Budget Office, I think most people give them high marks for being nonpartisan, being credible in what is a tough job. I mean, lots of people say, oh gee, there are all sorts of unrealistic assumptions that are built into how CBO does stuff. And I'll say most of those unrealistic assumptions actually are not CBO's, they're the way that Congress wrote the bill. So Congress may say, come 2017, people are going to jump up and dance on the head of a pin like angels. And CBO will say, gotcha. Dance on the head like angels. We'll try to score that. If the law is silly, CBO tries to estimate the cost of that. It's not CBO's fault that there was a silly provision in the law. So that's a lot of what happens. So that's not the scorekeeping fault. There were weird assumptions that were built in from the beginning. Now, the second question is, sort of, are there costs, or is it saving money? Is it saving? Is it costing money? That's right. The expansions are costing money. CBO said overall the whole package saves money. I tend to think CBO is credible. I think on balance it is saving money. But again, some of these things are hard to say. And what you get at is the real frustration that I think happens in Congress, happens in legislatures. You say, so we did these things. Did these things save money? And the typical answer is, well, we don't know. And part of the reason we don't know is because in many cases, the way CBO, the way your state budget offices do these things, is they have an incremental way of thinking about budget. So they have a baseline. And the baseline base is what's the most recent evidence we have about what spending was. And then we assume that we're assuming for inflation and other changes of legislative provisions. The problem is if you made changes, this gets incorporated into the baseline. So consequently, you can no longer detect those savings because they got buried in the baseline. And in many cases, there are savings that may actually occur because of things like hospitalizations. But people aren't tracking that from a budget perspective in terms of trying to figure those things out. And that's where you may need other research methods or other ways of analyzing whether they're savings. And in some cases it's easy, some cases it's hard. I will say it's tougher in states because what happens is, unlike CBO, CBO is a pretty big office. The total number of health analysts at CBO these days, I'm not exactly sure, my guess is maybe 40.
Yeah, they doubled between directors when Orzay came over.
Yeah.
We almost doubled the health staff.
Yeah.
Which was, we were thrilled to see that.
Whereas typically, and I've trained a lot of state budget officers, there's like one health budget officer who's assigned to it, and this health budget officer is also doing education in parks. So this is the problem: is that person's scope and expertise is limited, and there's a limited amount of data. So that also makes it tougher at the state level.
I just want to piggyback off of one thing you said, which is the design of the bills, because that's absolutely true. And this speaks to what I was sort of telling earlier about a lot of the payment reductions on the Medicare side. They're not sustainable. This isn't from where I sit on the budget committee. This is from CBO and Medicare. But the assumption that was made, and they had to make it because it was in law, was that the payment rates are going to be reduced a certain amount every year. And that's what generated a lot of savings to help pay for the bill. Well, and you debate whether it was paying for the bill or going somewhere else. But the Medicare cuts that were contained in the ACA are largely unrealistic when you see, when we talked about access earlier, the payment rates that will occur in Medicare and to some degree Medicaid under the ACA are going to make encouraging providers to come into those programs even harder. And so what CBO and Medicare trustees have said is, it is unrealistic to assume that Congress will allow that to happen. In other words, that we will replace those payment rates. And as history, if you go, the budget committee did a paper on this, if you look back at the 5 or 6 major Medicare bills that we've done over the past 2 decades or so, a lot of the Medicare cuts that we made as payment, as offsets, were put back subsequently. So one of the largest pay-fors for the ACA, we have argued, will eventually turn around and disappear. The iPad is a great example. It's theoretically designed to hold Medicare spending at a certain rate. If that were to happen, you're assuming essentially that Congress won't override what an administration is going to determine, and it's any future, I mean, this one is a future administration will determine as payment rates. And that both of these organizations have said it seems extremely unlikely given congressional behavior over the past 2 decades.
Patty? And then you.
Well, thank you very much. It's been terrific, for all of us from the states to be able to just sit here and talk with you on these issues. It's like I'd be writing 22 emails that would take 6 months to get answers on, so we really appreciate it. And I have like 5 other questions, but what you just brought up now is a huge issue to a lot of us in the states that are already, or I don't know, in our state, and I'm from Illinois, and so we have a $17 billion Medicaid bill right now. But what you just brought up, and Leighton, what you had, because I took notes on all the major issues that we would see the change in the Medicaid rate for the primary care physicians, when they raised that rate to go up to the Medicare rate, but you didn't mention, but then Matt did, which is huge in what you were just talking about now, is the reduction in the Medicare rate for the physicians. And that's already, in my area anyways, I'm getting calls from people all the time saying that the doctors will not take them anymore because now they're on Medicare. And so that's where I see, and then, that will be a political problem, because when that really takes place, how are they going to say that, they're going to reduce those rates? So what I see happening is the huge Medicaid expansion, and then now the reduction for all the people with the senior citizen boom taking place as a catastrophe when they really do reduce those rates. And that's supposedly how they were going to pay for the whole Affordable Care Act, or a lot of it anyways. Isn't that correct?
Yeah, there was about, our latest estimates, and these are 2012 numbers, so it's the last time that we really sort of got a good look at the inner workings of the law. It's about $1 trillion in revenue that, taking into account all the, and that's taxing, so when it comes in from tax is about $1 trillion, and about 716-ish came from Medicare. And the bulk of it came on hospitals and associated inpatient clinics. And then there was about 150 of it coming from MA side, and then a whole host of cats and dogs for the Part B side. And you're right, and this is I think what we were talking about sort of earlier, is just push and pull between, is the bill, the law, a net deficit reducer, and what can we do about access, right? So at the federal level, we look at spending and we look at access. And the law was passed under the premise that we won't add a dime to the deficit, right? And that's where these cuts came from. The reality of those cuts is just starting now. And so and this sort of gets back to the larger topic of what is going to happen to the law. One of the things that I have found so fascinating about Obamacare really is the delayed implementation, right? So when it was originally passed, none of this stuff was really happening. It didn't happen for 3-4 years. Smaller pieces have slowly start happening. The provider side, which you just talked about, the cuts on payments, we're starting to see that now, and we're starting to see the real conversation.
Excuse me for 1 second. When is that date that the reduction of the physician?
So they are staggered, right? So they don't all happen on one day.
Okay.
Some of them happen, right? Some of them happened on day one. The bulk of them will have already started. There are several more that are coming, but the bulk, this year, and so 2014, the law was passed in 10, right? 14 was the year it really started. And what's interesting is next year will be our first year of audits, penalty payments, employers who thought they did something and then didn't, people who thought they got a subsidy but got too much, people who thought they bought insurance and didn't get insurance. That is something that we haven't seen yet. That's coming next year. And so I tend to think back, people talk about, if we think back to the Medicare catastrophic coverage, that whole debacle, right? That was passed, signed into law, and then 2 years later, seniors were pounding on Dan Rostenkowski's car. Yeah. And that thing got repealed. This was different in the way because it didn't happen right away. It's going to implement over a longer period of time. So the debate over what happens to the law is going to be protracted as new things happen and new things don't. He's absolutely right. We are in our first open enrollment period, but we haven't gotten into the audit phase of it yet. That happens next year, and that's going to cause a whole new set of questions, debates. What do we do? What don't we do? How does this law unfold? So the access problem is real and happening now.
It is happening.
And the question is really, when we were talking about the fiscal nature of the bill, of the law, are we going to stick with what was written on the page? And this speaks to what we were talking about earlier on the Medicaid phase-down rate, when going from 100% to 90%. Are we going to stick to what the letter of the law said, in which case we are going to have continued access problems? States are going to start bearing burden both on the provider side and on the bill side. Or are we going to change that, in which case our entitlement program, our entitlement problem, the fiscal nature on the federal budget side, which we've been talking about, is going to get that much worse. And then where does the revenue come to pay for this stuff? Is it, again, a mix of borrowing, taxes, and benefit cuts? How do we meet those out? And then the state conversation, where does that come in? So,
can I try and answer what I think was part of a specific question you had, which were asked about Medicare physician payment cuts. And that actually wasn't part of the ACA at all. This actually tracked back to a 1987 law. So it goes way, way back that there was a provision set that tried to set up a target for how Medicare would set physician payment rates. And it was a fairly complicated, and when all was said and done, totally unrealistic. The net effect was that fairly soon it became clear that this formula And what the formula basically said is if physician spending is over this target, we are going to, on a percentage basis, reduce how much Medicare pays physicians. And this formula was written from that base of that law. Fairly soon in, a few years after that law was passed, they were missing the target. So the problem is to fix the law entirely would cost probably a couple $100 billion, maybe $300 billion, it depends on how you fix it. What's happened for every year for a dozen years, 11 years, we've been sort of coming up with a patch where, maybe we provide another $10 billion, $20, $30 billion, but the number keeps rising, to sort of say, let's hold physician payment rates up for a year, and then we'll deal with the next crisis when it comes next year. And of course, it comes every year, pretty much. So, it's one of these things that has a fairly long history of why Medicare physician payment rates are going down. It was an unrealistic law to begin with. It's sort of a shame Congress had the opportunity. There was a lot of interest in trying to have a permanent fix to the Medicare physician payment rate. It didn't happen for all sorts of reasons. Maybe there'll be another opportunity next year. The truth of the matter is, I don't think anyone in reality thinks that Medicare physician payment rates will be cut. But the problem is that for them to not be cut, Congress needs to come up with a patch every year. Every year, that patch costs money.
Just to piggyback on that, they were the initial House version of the law. The SGR patch, which I think is what it's called, was included in Obamacare. It was included as part of the bill. It was stripped out when the Senate sent it back. But those are two somewhat separate issues. There are $700+ billion of cuts in the MA program in the ACA, and they do fall on both providers, whether they're physician specific or in the area where they provide. They're still there. We have the value-based purchasing program, which will be up and running next year, which will have a direct impact on the individual provider. On the SGR side, both and this is the patch that some of you hear about, the House and Senate each had their own big 10-year fix, and we got help from CBO this year and at the end of last year, dramatically reducing the cost of a full-on replacement for this formula that's been broken. It was stalled. We have patched it through March of next year. So the cuts were staved off until March, and then we will revisit it again then. And the question is, how long is the patch and how expensive? Because healthcare costs now are going back up. And so one of the reasons that the patch got cheaper was the rate of increase in healthcare costs declined over the past 2 years. There's debate about why, but it declined. And so the SGR cost dropped. And we're now coming back up again. And so the cost tends to go up.
Do you still have a question?
No, mine was SDR.
Okay, I thought we got you. And
My question goes back to the nutritional, the SNAP program and nutritional values for food. First question being, I don't know what work has been done or what efforts have taken place with regard to SNAP eligibility in food deserts with farmers markets and that sort of thing, and what is the national support that we have for that. And then secondly, when we look at the success that we've had with the caloric intake and the nutritional value on the fast food menus in some communities, have we looked at those SNAP values being looked by label, by nutritional value on the label of the food versus the type of food, the sports drink? Has that conversation taken place?
I'm not aware of, in general, the way that SNAP benefits are dictated is based on a federal level formula that's set in the law. I'm not aware that there are any particular provisions that say maybe you can get a little more money if you're living in a food desert area versus not. It's an interesting notion. Every now and then people have brought up the idea of, well, gee, shouldn't you have some adaptation if you're a diabetic or if you have someone who has a genetic metabolic disorder? Shouldn't you be able to increase the SNAP allotment that goes for people who have special dietary needs? I haven't heard one about a food desert idea per se, and I don't know if SNAP does anything about that. WIC, there's a farmer's market component
Right.
that permits WIC vouchers to be used in farmers markets that are often, sometimes in food desert areas, sometimes they're in plush urban areas too. But, you know, that tries to sort of make sure that people can get, you know, farm fresh, healthy food and a little better access. But you know, that's what I'm thinking of.
I'm aware of things that have been done in individual states to allow food stamp access in farmers markets. Things as simple as at my farmers market, the Kentucky Extension people ran experiments where you can come and swipe your card, and it includes like all my young friends who never have cash on them, so they can swipe their card and they get $20 worth of wooden chips, just like somebody who swipes their food stamp card gets $20 of chips, and then the chips are used in the market to purchase the food. And I don't know that it's been published, but the Kentucky Extension Office found that it increased the total take of the farmers market to have this available, whether it was from EBT cards or young people who never have cash on them, and you know, now because every vendor doesn't want to swipe a credit card, but that's been successful, and I mean, that's just one I'm aware of, but I'm sure there are lots of things out there like that with farmers markets.
I'd like to hear from each of you quickly, but maybe there's not time, but Professor Koo, there's a popular story, I think I see it every few months, that Meta Global Analysis, the United States healthcare costs more than other industrialized nations and delivers less. Do you buy into that story at your level?
Well, I'm willing to start, and the answer is sort of yes, sort of no. For sure, we spend the most of any country per capita. And it is true that some of our health outcomes are not as good as health outcomes in other countries. It is not always because our healthcare system is not working well, but because there are lots of things that go on to add to health status. So what you smoke, your other health practices, you put a seatbelt on, all these things add up in terms of, you know, leading to health outcomes. But it's true that we spend a lot of money on healthcare, and we don't necessarily have the best health outcomes. I will say it is also the case that, as it's been put to me, in many other countries, physicians are often it's a sort of middle class occupation. It's not necessarily a highly remunerated occupation. Hospital administrators, in many cases, also they're you know, sort of mid-level professionals. In the U.S., we have tended to be willing to pay doctors and hospital administrators a lot more. Because of this, we probably get smarter people in there who are willing to work hard. So in that regard, it has a lot of benefits. But on the other hand, it drives up some health costs.
So I absolutely agree with that, and I think it's a good question. But I think that there's a broader question. It's not just, you know, if you look at what kind of predictors of what your healthcare costs and needs are, it goes well beyond just the medical care. I think there's something like 90% of what determines your health are the social determinants of health rather than just the medical slice of it. And I think in a lot of other countries where we see, you know, much better health outcomes over, you know, lifespans, we see that they also invest a lot more in things like education and housing and things that our country, we don't necessarily spend as much than those countries do, but they do in the long term drive healthcare costs and needs. So I think there's the social determinants of healthcare is a really big piece of it that we don't think about it in the same breath or in the same, you know, conferences and conversations, but it's a big part of it.
I would agree pretty much with everything that was said here. I would note that in the comparisons, the one thing I would add to this is that countries measure these things differently, especially when it comes to the cost of the service, and they also measure which populations use it. Again, so child mortality is a great example. What constitutes that is different across a whole range of countries. So when you're comparing these statistics, it's not necessarily apples to apples.
Any other questions?